by the time we do that, we will have a form that we can work with, and then we won't have to do all that over again. We can take comments and proceed. And I hope you're okay with that, because I don't know what else we'll do except look at each other.
Order beer and pizza.
You're the one with the gavel.
Yeah.
Okay.
No, these are just, sorry. And do you want to do like provisions of each bill, or do you want to just do a quick summary of what they are?
Why don't we just summarize, if there's anything that, they tossed out. Actually, what we don't want to do is replay what we did last year. I think for the most part, with a few changes, everybody knows what we're dealing with, what we're talking about. So, Sarah, if you just sort of summarize and see where we are when we finish doing that.
Suppose the best way to do this is to just go in numerical order.
I think so.
Okay. We have a number of COPN bills tonight, so we'll start with 1420. This bill just repeals the requirement for a certificate for projects involving mental hospitals or psychiatric hospitals and immediate care facilities for individuals with SA. Our next bill, 1544, provides an option for alternative plans of compliance for conditions on certificates. It provides that in cases in which the certificate holder holds more than one certificate of the company with conditions, the certificate holder is unable to satisfy the conditions of that certificate, they can satisfy the conditions by the provision of care at a reduced rate to indigent individuals in the excess of the amount of one certificate to satisfy process work. Moving into 2101, this bill really relates more to data collection and definitions of charity care. So it defines charity care bad debt. So it defines charity care and bad debt. It establishes a standard for determining the value of charity care, restates the methodology for determining charity care when we're looking at conditions, and requires certificate holders to provide documentation of the amount of care provided to patients in the documentation demonstrating compliance with their certificates. It also provides that data required to be provided to BHI include data and information about parent companies of the healthcare provider and any subsidiary companies. Also requires that every medical care facility for which a certificate is issued with conditions report data on the total amount of charity care provided, the number of patients to whom it is provided, the specific services delivered to patients that are reported as charity care, and the portion of the total amount of charity care provided that each of those services represents. It also requires hospitals that receive dish payments to report the number of inpatient days attributable to patients eligible for both Medicare Part A and SSI, and the number of inpatient days attributable to patients eligible for Medicare B that are not receiving Medicare Part A. Related to that one, sort of similar to that one, we have HB 2225, which requires centers, organ and tissue transplant, certain open heart surgery services, certain neonatal services, and certain medical care facilities located in localities that meet a threshold based on population density and how localities fit together. I don't know how else to explain that in a short way, briefly. Then we have the second phase, which would be January 1, 2018, so it's a slightly delayed effective date for phase 2, and that would repeal the requirement for imaging center services. The bill also creates a new permitting process for the categories of facilities, so as one facility or service or requirement for certificate moves from one out of the requirement for a certificate, it will move into the permit requirement, and that is again a 2-phase process, and makes a number of changes to processes and procedures for certificates. The final bill is Delegate Scally's HB 2458. That bill also makes a number of changes to the processes and procedures for COPN. I'm not going to walk over those because we've seen, again, many of those last year. It does remove specialized centers or clinics or portion of the physician's office for lithotripsy, MSI, or medicine imaging from the reviewable list of medical care facilities, and makes a number of changes to the CAPCA and PASHERS. I don't think I'll go into too much detail on that, since we'll probably walk through those as well. Those are our COPN bills, Mr. Chair.
Thank you, Sarah. I think you noted, and I was a bit distracted there, but I think you noted that in Dr. O'Bannon's Bill 2337, that most of the rural facilities stay subject to the certificate requirement. Most of the urban facilities are subject to the permit requirement. We now have a quorum, but we don't have all patrons here. Ed, since you are first on my list, why don't we make an attempt to get through your existing quorum?
I think first up, if we could actually start with 2227. And Mr. Chairman, what we are trying really to address here, there has been an ongoing sort of a battle for trying to establish a second NICU in the Roanoke Valley. And my understanding, that was really the primary purpose of this, was to sort of get that conversation underway. My understanding is that the two parties that are involved here are actually scheduling a meeting that, I think the scheduling of that is going to come down to tomorrow, to try to come up with their own plan, which is far better than us trying to come up with one here, I believe. And if that can happen, then I think the best thing to do, particularly in light of the fact that there are some areas of this that are, I think, going to be probably touched on in much broader legislation that you will hear later, that it might be a good idea for me to request that this be laid on the table. If the meeting does not happen, then I will certainly let the subcommittee know, but I think that might be the best thing to do with that legislation at this juncture.
Laid on the table or taken by today?
I think we can go ahead and lay on the table. Would be fine.
What's the likelihood of that meeting happening?
I think there's a pretty, I'm fairly certain that meeting is going to happen.
I don't need to remind you or anybody else, we're on a short view.
Short, yes, sir.
And so we don't have many places to put things for another hearing.
And I do understand that.
So at the patron's request then, House Bill 2227.
So moved.
Second. It's been moved and seconded that we lay it gently on the table. Any discussion? We don't have discussion.
charity care. The idea here being that we make sure that those that are in a COPN situation would establish what charity care is, make that very clearly available so that all of their patients would be able to know up front what the criteria are for receiving charity care, either free or reduced payment, that those criteria would be readily posted and available for them, and that there would be a distinction between charity care and bad debt, so that we don't see people taking what would not qualify ordinarily as charity care, the bad debt be just moved over into a charity care bucket, and so that we can really sort of make a distinction on that, and we can keep track of what's going on with that as we're moving forward. I do have some line amendments that I would like to ask if we would entertain, and there are two. They are the same verbiage, but on line 247, it's not legal, so that's going to be on the original draft. And I apologize, Mr. Chairman, but 247. Made it wrong spot here. Let's see. Actually, that's the wrong line numbers here, Mr. Chairman. Line 280, 281, I'm sorry. After surgeon, if we could insert who has been issued a certificate pursuant to section 32.1-102.2. And in essence, that is, would be a dentist who has a certificate of need in their practice.
Mr.
And then the exact same verbiage on line 291 after osteopathy. Insert who has been issued a certificate pursuant to section 32.1-102.2.
Dr. Garrett. And Sarah, question for council. So right now, the language alludes to pursuant to 54.1-279.1. The other one's changed to a different section, but as a practical matter.
No, my understanding for line amendment for that was that we're not striking any language.
We're not striking
What
any
we-
language.
And what we probably want to do is instead of locating it on line 281, move this to line 282 after the section that your Delegate Garrett has mentioned. So this will actually read, every person licensed to practice dentistry who is registered with the board as an oral and maxillofacial surgeon and certified by the board to perform certain procedures pursuant to 54.1, 27 and 9.1, who has
charity care, and if they meet those qualifications, then that patient would qualify for charity care. Bad debt is someone who does not meet those qualifications, should have the resources and means to pay, but just doesn't pay, and through the collection proceedings, they're just not able to get anywhere, and they choose to write it off as bad debt rather than pursue it into aggressive collections situations. So,
Thank you. I'm just trying to maybe hit off some other questions.
Mr. Chairman.
Doug Garrett.
And I want to follow up your line of thinking as well, Doug, I had to make sure I understood, because I thought I understood until you said what you just said. So somebody who's low income that qualifies for Medicaid is now insured under Medicaid. If in fact the provider of the hospital is reimbursed by Medicaid for this low income person that can't otherwise afford stuff, does your bill still qualify that as charity care?
if that's reimbursed, then they've been paid. That would not be,
Okay.
or perhaps the portion that they are discounting might be, but there again, that would have to be notated in the criteria that they establish as to what portion of it is going to be charity
So,
care.
Mr. Chairman, just as a follow-up, one of the challenges Delegate had is this concept of discounting of care. So we discount relative to our charges versus our cost versus the fee schedules. Those are really three different sort of entities.
Absolutely.
Okay?
And Mr. Chairman, what we're trying to get to is reporting that allows us to see all of that morass, because it becomes very, very cloudy as we're trying to compare what we do in this whole process with COPN. It becomes very, very hard to untangle the knots, and this is just an effort to try to begin to gather some more data, establish criteria so that we know this is how we're defining this in this system, so that we can know what buckets we're looking at and know it ahead of time.
Mr. Chairman, just one other follow-up.
Doug Garrett.
So Doug had every person licensed practicing, they are going to be establishing charity care policies governing the provision of dental services for themselves, for their practice.
For themselves, that practice, yes. If they be, again, for the dentist practices, there again, that's only the ones that were under a COPN to begin with. So that's gonna be very, very few.
Okay?
This is primarily targeting at the hospitals, but we have the dentists and the individual practices in the event there are any of those that do have COPN, hence the verbiage that we just added on those line items.
Thank you.
Okay, are there further questions from the subcommittee members? If not, I think we're ready to accelerate a little bit. So anyone in the audience have questions or comments for Delegate Head? Hearing none, what's the pleasure of the subcommittee? On House Bill 2225. I don't hear a motion. I don't know if we
Mr.
need.
Chairman.
Maybe we need a timeout.
Mr. Chairman,
Delegate Orr.
I move to recommend reporting.
Second.
It's been moved and properly seconded to report the bill. All those in favor, please say aye.
Aye.
Opposed? Bill's reported.
Thank you, Mr. Chairman.
Okay, Delegate Byron.
Okay.
House Bill 2021.
This isn't finance? I'm in the wrong place.
Sorry, can't finance it, I just, issue. One of the areas that I think we all identified, and an area that I was focusing on this year, I had quite a few bills in last year, as you all know, dealing with supporting reform of COPN. One of the areas that I started working on it as early as this summer with staff, thank you, Sarah, for the work that you've done still, and sat down with BHI, was to look at how charity care was being reported by the hospitals and to be able to make sure that we had a definition that was uniform, that clearly stated what services were being provided, so that we could look at the data and have accurate data in evaluating what is being reported under charity care. We all have seen that everyone is using some variations in their methodology and making sure that we have something accurate in place, and that the best venue seemed to be we have all payer database claim that has information coming from insurance providers. We have BHI. All of these, I guess, are handled by the Virginia Department of Health, but the BHI seemed to be the best venue for obtaining and collecting this data and ensuring that we have a uniform definition so the information is equally the same. So it's very important that, I think if we have one provider that's doing a heart transplant, let's say, and we have another one that's doing it, there should be a single standard so that we know how we're going to measure those charges and costs. And that's really what's at the heart of this bill. I know I got some feedback from the task force, and I have a response to that when the time arises, unless the committee has any particular questions. I think that the best definition, we've been working on this for several years, is that if we don't go back to the beginning and say that charity care means that when the services are provided and it was determined that no payment was expected, otherwise we end up with charges that no one can understand, because you start filtering in debt into that and all sorts of other parts of those charges. So the bill is not that complicated.
Thank you, Byron. Questions from the subcommittee? Anyone in the audience wish to comment?
Good evening, Mr. Chair, members of the subcommittee. Lauren Schmidt speaking tonight on behalf of the Coalition to Reform COPN. I just wanted to briefly state that we support this legislation. Thank you.
Thank you. Anyone else wish to comment? Yes, ma'am.
Thank you, Mr. Chair, members. Jill Hankin from the Poverty Law Center. I support the data collection. I think it's really important. I would just point out that this bill does value charity care according to the rates of the Medicare program. Other bills that are coming before you value charity care according to the payments made under the Medicaid program. I would submit that it's most appropriate, since we're talking about very low income people, that the value of the charity care provided should be valued according to Medicaid reimbursement, which would typically be lower than Medicare. Just to find
process, and after working on the Deeds Commission, knowing the need, that just didn't make a lot of sense. I didn't expect this bill to be here tonight with all these other big, huge bills. Quite frankly, I was viewing it more in the mental health vein, and I've had a couple of folks come to me with different amendments, whether from the physician side, from the hospital side. Some of them made sense, some they didn't. Before I decided which ones, I figured, why don't I have the bill tonight for the committee, and I pledge everybody I would keep working to input amendments as they made sense. But I wanted the bill in its basic concept to be heard before I went down that road. But I pledge to work with anybody who wanted to work on it. Mr. Chairman.
Dora.
Peter, this bill's been out there a while. Have you had any stakeholders come and offer suggestions?
Mr. Chairman, I have, and the reason I didn't go ahead and implement them is because some of them are very different, and being that I was not part of this last year, I said, you know what, I'm going to let the committee hear this the way it is, and then they have more experience, because I think some of the amendments were familiar to you, and we're not familiar to me.
We all appreciate you said about it.
Correct. So I kind of like the bill the way it was, but yeah, it's still there. But if we need to work on it to get more support, I'm happy to do that.
Anyone in the audience wish to speak to House Bill 1420?
Mr. Chairman, members of the committee, James Pickle with the Psychiatric Society of Virginia. Concur with Dale Farrell. We think that we certainly need more mental health beds, and we definitely need more substance use disorder beds, and therefore we'd ask you to act favorably upon the bill. Thank you.
Thank you.
Mr. Chairman, members of the committee, Brett Rawlings, Virginia Hospital Healthcare Association. We were one of the stakeholders that reached out to Delegate Farrell. Our main concern about the bill, with any bill considering deregulation of services, we want to make sure that there are strong provisions in there requiring deregulated providers to provide charity care services, participate in Medicare and Medicaid, have financial assistance policy, and other measures that will level the playing field and truly provide access to Virginians. And so that was the gist of our comments to him, and hopefully we'll be able to work with him on this as the bill proceeds. Thank you.
Mr. Chairman.
Dora.
But Brett, aren't we looking at a broad landscape of inpatient treatment? This is an area where we're currently incredibly lacking in space and availability as you look at the whole system across the Commonwealth.
Mr. Chairman, yes, there have been a lot of investigations and taking a close look at the availability of psychiatric beds in the Commonwealth. I think it's very clear we need greater access to psychiatric services. Looking more closely at some of the issues around bed availability, we certainly need to better understand the myriad issues involved there. And so we want to make sure that the other comment that we would have on this is just that simply creating more beds is not enough. We've got to couple that with funding and other issues, community service and support, along with other behavioral health issues.
Mr. Chairman.
Dora.
But Brett, to that very point, I understand all the other issues, but if the COPN process, which brings certain costs, becomes the barrier to an institution wanting to expand in this area, because I recognize this isn't a real profit maker within the hospital system, quite the contrary, but it is an area where there's a critical need. And I guess my question is more to the point, would you not agree that the current costs of going through the COPN process to add these types of beds may in and of itself become the deal breaker financially for the hospital wanting to even go forward in that area if they think it's in the best interest of the community, because they gotta be able to keep the doors open for everything.
Mr. Chairman, that is certainly a situation that we would seek to avoid. And again, I think the comment is fairly straightforward that we had, which is let's not convince ourselves that simply deregulating the services will be sufficient, and I'll just leave it at that.
Mr. Chairman, I am under no illusion that this is a silver bullet.
Oh, no, nor am I.
Delegate O'Bannon.
I don't want to prolong this, but have there been beds like this denied by the current system? And if so, how many?
Mr. Chairman, Eric Wooding, Department of Health. Yes, there have been 2 applications that were denied. I don't know how many beds off the top of my head. Do you remember how many beds? They were freestanding facility hospitals, so we're a good number of beds.
So, okay. And were you out there when the DVHBS
ma'am.
Mr. Chair, members of the Sub-Committe Enlargement Coalition Reform COPN, we do support this legislation. I think Bill Farrell explained it very well. There are people who want to provide this service. We should let them do it. Thank you.
Folks in the audience who wish to comment? Dr. Farrell, let me ask you a question.
Yes, sir.
As far as suggested amendments, are you listening? Are you
I hope, Mr. Chairman, after workers' comp and then the really fun eye bill that I had recently, that I hope at least people know that I am someone who tends to want to work with folks and see if we can reach some sort of agreement. So I would happily do that. Part of the reason I didn't get into that because one, in the interest of time with the short session and dealing with that eye bill took a lot of my time from trying to work on the amendments. So my hope was, I like the underlying substance of the bill. If I need to amend it and get more parties interested, I'm happy to work on that. And Mr. Chairman, I hope my reputation before, maybe I'm full of it, I just think it's a self-reputation, I'm completely wrong.
Yeah.
But I hope that you'll understand, they can come by and I'll listen to work on them.
Mr. Chairman,
Yes, tell me more.
I move to report. Second.
It's been moved and seconded that we report the bill. Any further discussion from the subcommittee? Hearing none. All in favor, please say aye.
Aye.
Opposed? Bill's reported.
Mr. Chairman, thank you for coming, sir.
Thank you, Dr. Farrell. Delegate Collins.
Good evening, Mr. Chairman. So my bill basically solves, the issue is that we have on our COPN, we have diagnostic centers that have to provide, they have to get their equipment. The one center in my locality has 4 set pieces of equipment. Obviously 3% has to be given to charity. So the X-ray machine, the MRI, the CT scan, and ultrasound. Well, what they're doing is they're exceeding it on 3 of the equipment, but not exceeding it on the other. So they're ending up being penalized for the one device or not making that 3%. What this does is say if it's an aggregate, that they are exceeding the aggregate donation to the community, that they wouldn't be penalized if one of their devices was not meeting that number. So the net effect to the community would be the same, it just that it would be an aggregate rather than an individual device.
Delegate Collins, when you talk about the community, how large a geographic area are you talking about? And I guess the premise being, if 3 out of 4 are complying and the other isn't, then isn't that kind of creating an anomaly as it relates to the system in that 4th area? Can you just elaborate on that?
Sure. They're not necessarily talking, excuse me, I'm sorry, sir? I'm sorry. I just came from court, so you have to excuse me for the decorum. So, in my jurisdiction, it's about 110,000 people are served. I can't remember if it was the MRI or the CAT scan that's not in demand. But the other device is being in high demand, being utilized by patients coming in. So they are providing the services necessary for the indigent community, our Valley Health, and also through our free medical clinic. But the other device is more of an emergency basis, and the hospital has one, so they're coming through to the ER. So they're just not having quite the demand for it by the indigent community.
Other questions for the patron? Brother James.
Thank you, Mr. Chair. I guess my question is, if I understand this correctly, wouldn't this reduce the total amount of charity care?
No, it's still going to be the same. It's going to actually, because all it's doing is saying you still need to make 3% on each piece of equipment. So there's 4 pieces of equipment, 12% still has to be charity care. But as it is now, it has to be 3% from each. 3% of the services have to be from each piece of equipment. So if one piece of equipment is only giving 1% charity care, but the other 3 are giving 5% charity care, then there's still the overall, that 1% is still being given, but there's not a demand for the other 2%. meaning that the innocent people aren't coming in, but we're not giving them a break for that. They still have to be responsible for that, but they have the other 3 devices. And I'm talking about my one locality. If someone has 2 pieces of equipment, then one piece of equipment is going to be making up the difference for the other piece of equipment that's not being utilized.
Mr. Chairman, thank you.
Garrett.
So, thank you, Mr. Chairman. So, Delegate Collins, so let me give you an example. So, we have 30 hospital systems statewide. Mine serves as a footprint or catchment area of a number of counties. They're intending to build an ambulatory surgery center in County A. They get a certificate of public need for that. They also intend on the other side of sort of, 40 miles away, 60 miles away perhaps, they're going to build another facility. They can't comply in the one county, but they're going to somehow make up for it in the other county. Don't we still disadvantage the first county? The whole intent of trying to provide better access to care across all of those counties.
Under your example, that was not the intent of my bill. My intent of the bill was not so that a hospital could open up 4 different diagnostic centers within a 100-mile radius of each other, and then take the advantage of this one over here, where they're doing a lot of charity care, and then apply that to this one over here. The intent was, when you come in and do a certificate of need, you say, I'm going to have an X-ray machine, an MRI machine in our diagnostic center. And then at which point they both have to give 3% to charity. The idea is if you have in that one location, if one device is doing 6% charity care and the other one's only doing 1% charity care, they're still in compliance with the charity care under their certificate.
Mr. Chair, follow?
Garrett.
So Sarah, how do we accomplish that? Because the verbiage he has doesn't do that.
So if I understand correctly, the issue that we're trying to sort out is that we may have a provider, a single provider who has multiple locations and therefore is acting across locations. We could look at an amendment to narrow the certificate holder to clarify that it would be at a single location. Would that address your concern?
Mr. Chairman, my primary concern is just if we're going to try to say to this, say, 6-county area that's served by one hospital system, that by this hospital now going in and saying, County A, we're going to improve your access to care. We're going to build a facility for whatever needs there. County B, on the other side of the footprint, we're also going to help you. They're not able to fully comply for a variety of reasons, whatever they might be in County A. County B gets overserved potentially, which is a good thing, a positive thing, but we effectively have said we want a certificate of public need that's actually going to help County A, and in so doing, we haven't kept our commitment to the residents in County A.
Mr. Chairman, and this isn't so much of the page because I understand his objective for the facility and the unique situation he addresses. I guess I'm wondering, is there anyone in the audience who can speak to the implications of this system-wide? And that may be addressed as we get to opponents, proponents. I'm hearing crickets. Nobody cares about this one.
Because it's so over.
Obviously.
Other questions for the patron? Anyone in the audience wish to speak to the bill?
Mr. Chairman, following up on Delegate Garrett's question, I'm going to move that conceptually we approve an amendment that would make clear that this would be within one facility. And let Sarah wordsmith that and then bring it before full committee and ask that she have that amendment available to all the subcommittee members prior to full, so that we may fully understand and be ready to go forward with it at that juncture. So I would conceptually move the amendment to the measure.
Feel your pain.
I mean, no harm to this, but I'm aware of at least one nice lawsuit where a local body approved something in concept. So if we chose this route, it would be to send it without a specific recommendation.
Well, I was going to say, as an alternative, what we could do is just let the matter go by its full subcommittee. Sarah could get the amendment language, and I, as the chair, could bring it forward without recommendation from the everybody's in
I would
agreement.
certainly support that procedural.
I'm moving to go 5 for today.
Doug, comment you?
I'm fine with
Just
that.
that.
I think.
Trust us.
I think I've said that from your position already in Winston Seaton, delegate. So that's, no, that's fine, Mr. Chairman. I think that we all on the same, I think we all agree, on what the goal is here, so that's fine with me.
Okay, without objection, Bill, go back to that.
Thank you, Your Honor. Thank you, Mr. Chairman. Sir.
Delegate Stop. You're turning the barrel.
Thank you, Mr. Chairman. If we're here again next year, we need a bigger room. Quite right. Mr. Chairman, I have a amendment in nature of substitute.
Substitution for you.
I'll share it with the delegate Scott. I'll share for hospital.
We need a motion on the substitution.
Move the substitute.
Without objection, substitute is accepted. Delegate Stop.
Thank you, Mr. Chairman. Before you, you have a bill that is a true effort to reach some compromise to move forward on this issue. I will quickly go through the bill as briefly as I can. It is a fairly extensive bill. I'll be as brief and then happy to answer questions. In summary, this bill removes the requirement to obtain a COPN for operating rooms and ambulatory surgery centers and health planning districts where utilization of operating rooms exceeds 80%. Additionally, this bill removes the COPN requirement for new psychiatric beds, takes the wording from Delegate Farrell's, but adds also the access and quality measures that we heard BHHA request. In addition to that, it repeals COPN for lithotripsy, magnetic source imaging, nuclear medicine imaging, obstetrical services, and requirement medical facilities within the same primary service area from COPN requirements. It does establish a permit process where the commissioner shall issue a permit for an operating room or ambulatory surgery center if the utilization of the operating rooms in the health district exceeds 80%. So what this does is it takes and establishes a need criteria rather than a geographic or rural, urban. This is a need criteria for operating rooms. It is the needs criterion that is currently established within COPN. It's what our current requirements are for issuing a operating room or ASC. It takes away the CON process for those areas that exceed that 80%. It facilitates increasing access to those areas. This bill also requires and facilitates the timely and rigorous review and update of the state medical facilities plan, which establishes the criteria and standards for determining public need. It renames the state medical facilities plan to the health services plan and exempts amendments from the state health services plan from the provisions of the Administrative Process Act. The
requires developing an expanded, expedited process for review of COPN applications, specifies what is considered to be a complete COPN application, and mandates that VDH to ensure that only data necessary for review of an application is required to be submitted. It establishes the State Health Services Plan Advisory Council to determine and to develop an analytical framework to evaluate appropriateness of continued COPN requirements for specific projects, to establish recurrent schedule of analysis of all COPN project categories, and develop recommendations based on the analysis and transmit them to the Governor, General Assembly, and Secretary of Health and Human Resources annually. It authorizes the Board of Health to promulgate regulations establishing quality assurance provisions of COPN holders and defines quality assurance as accreditation by a nationally recognized accrediting organization as approved by the department. It requires VDH to establish a registration project for any or process for any projects no longer subject to the COPN process in order to retain the obligations to provide charity care and to require accreditation from nationally recognized accrediting organizations. It requires VDH to develop an online library for all relevant COPN information and documents, and an automated tracking and posting mechanism to make letters of intent available to the public as soon as they're available. Requests the Secretary of HHR and VDH to study charity care services and recommend a change to the definition of charity care and report to the General Assembly prior to the 2018 session. And requires the Secretary of Health and Human Resources to convene stakeholders group to explore appropriate authority for the State Health Commissioner to impose additional conditions on COPN. That is a short summary. I'm happy to answer any questions.
Are there questions from the subcommittee?
Commissioner.
John Kerry.
So, Dr. Saad, first of all, I want to thank you, sir. You have been really, really working mightily on all this issue 2 years ago, last year, and so on. I want to thank you, sir, for your diligence, because I truly believe you're trying to get it right. Help me understand what the role of this new advisory council would be vis-a-vis the Commissioner of Health in ultimately giving the green light within 45 days for a healthcare system or whomever that wishes, or providers that wish to put in a new project.
So the commission does. I mean, that goes through the regular process there. The commission is set up for the things that we have talked about today. We've heard about it in Delegate Byron's bill. We sit here on a regular basis and try and make decisions without adequate data. And quite frankly, I don't think that we are well positioned to take and make these decisions. I think we need to have, first of all, an analytic framework that we make these decisions on. We need to have a way to get that information in and that information analyzed. And then we need to make intelligent decisions based on what that information says. That's the function of this committee. Instead of sitting here saying, what do we think the impact of this is going to be? Let's make this on the best practice on analytic data that we have available to us. And then we can feel reassured that we aren't hurting more people than we're helping by the actions that we're taking.
So, Mr. Just a quick follow-up.
No, you can.
So I guess my real question, Dr. Sally, is, so the council's going to do all of that groundwork and come up with all the data and look at analytics and so forth and so on. But relative to today, which requires ultimately, through a laborious process, a signature of the Commissioner of Health to approve a certificate, is it your intention or envision that this council would now vote that and judge and sign, or council is just going to advise the commissioner? Ultimately, the commissioner would still sign.
Yeah, there's separate processes that we're looking at. So the commissioner's role doesn't change as far as that. The commission is sitting there to make recommendations to us, to the governor, on what we should change. It's not approval of individual COPN process or projects.
Thank you.
Mr. Chairman.
Laura.
Delegate Stolley, yeoman's work, as always, that's always your trademark. I'm going to propose one possible amendment on line, page 28, line 721. After the word including, striking, evaluating possible funding mechanisms to support regional health planning agencies and the premise behind that, we did away with all the regional planning agencies except one.
Could you direct me to where we're at?
On page 28, this is the enactment clause on line 721 of the substitute.
Thank you.
Taking out that they're to evaluate funding mechanisms for the one planning entity, planning agency that is at their own choice
Advisory, State Health Services Plan Advisory Council meets and review that the first order of business that will review will be diagnostics.
Joe Scott, this is a ninth
Enactment clause.
Everyone have that?
Question.
Go to Matt.
So the purpose of this would be to clearly put diagnostic imaging in play in the COPN reform process.
Mr. Chairman, Delegate O'Banion, I think that every aspect of COPN is in play in the COPN process, and I see that as the primary function of this committee is to evaluate those remaining things. What this says is we're not going to make that last, we're going to make it first in that evaluation.
Right, okay.
Thank you. I would propose that.
Without objection, the enactment clause number 9 is accepted.
Mr. Chairman?
Doug Carey.
Line 342.
I'd already put my glasses away.
Are they 1.5s? Are they 1.5s on?
No, they're higher than that.
Where's Farrell? He has the optometric. No, just kidding.
I'm sorry.
Kidding. A little levity. It's late in the day. Hang with me.
I'm sorry, tell me.
Technical,
Yeah.
It's a typo.
Yeah. At 342, November the 1st of 2016 is already transpired.
Correct.
Should be 17.
Should be 17.
We'll let you know we're actually reading bills.
Other questions or comments from the subcommittee?
I guess on that very point, presuming this goes into effect July 1, can they achieve all of those goals mandated there by November?
Mr. Chairman, Delegate O'Rourke, I would say that I have not talked to the Secretary directly on this. This was their position last year, felt that they could accomplish it. I would have to verify with them again.
Mr. Chairman, I guess, if you can do that, presuming this is acting unfavorably before full committee, we may want to conformity in most of your enactment clauses, you have a date certain or as soon as possible thereafter, so we could easily full committee if that was what the Secretary felt was necessary. Don't be careful what you ask for, we might give it to you.
Is there anyone in the audience who wishes to comment?
Mr. Chairman, members of the committee, Brett Rawlings from Virginia Hospital Healthcare Association. We've not taken a close look at the amendments yet, but with respect to the bill that was introduced, we fully support the measure. It was entirely consistent with the bill that was filed by Delegate Stolle last year, which we supported then. We'll need to take a close look at the amendments and find out exactly what those entail and have a better understanding. But again, in concept, the framework that we have here, creating an analytical framework, creating a council that can assess certificate of public need review and its appropriateness for various services in the Commonwealth is a step in the right direction. It provides a path forward for us. And for these reasons, we support the legislation. But for the amendments, we need to take a close look at those. With respect to the services, ambulatory surgery centers, not the first place we want to start in terms of looking at deregulation for several reasons. In large part, where we are today in healthcare and all the changes that are going on, we don't want to do anything to destabilize our healthcare system. So again, we thank Delegate Stolle for his work on this bill. We again think this is a path forward on COPN that we can get behind, and we appreciate the work of the committee on this.
Thank you, Mr. Rawlings. Anyone else wish to comment?
Mr. Chair, members, Sub-Committe Marchment with Coalition to Reform COPN, and we also haven't had time to really look through the bill, but we want to thank Delegate Stolle for all the work he's done and for hopefully we can collaborate on this and work together, and we just want to thank you for that. Thank you.
Any further comment? Delegate Stolle, I feel like we're making progress.
Ask me next week.
Move report.
Second.
Amended.
It has been moved and properly seconded to report the bill as amended. Any further discussion from the subcommittee? Hearing none. All in favor, please say aye.
Aye.
Opposed? Delegate O'Bannon.
Thank you, Mr. Chairman. I have a substitute as well, 2337. And that.
I'd just like to thank all the trees who so unselfish and gave who so loved.
Did you have a copy, Don?
So I may depend on Ms. Stanton's help on this, and I may do this at a little higher level, because I think Elder Staley explained a lot of what's in this bill as well. Many of those procedural pieces are in my bill. The advisory committee is not in my bill. So there's one difference. And just in the big picture, I think what Elder Staley has proposed is a way to go at this at a statewide level, which would pull in all the parts of the state at a volume-based level, which is certainly a good concept to start with. As you know, we had a bill last year, which was based more in the sense of reforming COPN and changing things in the more populous areas of the state, which in an effort to address the concerns that many rural hospital systems and hospitals have had about their concerns for deregulation. So what we have this year is a bill that's a little different in the sense that it defines health innovation districts. And those are based on population density, and I'll call your attention to that definition. It's a locality with a population density of at least 200 people per square mile, or a locality that is contiguous to such a district with a population of 75,000 people, or a locality that doesn't meet those population criteria, but is contiguous to a locality that does meet them, where the local governing body adopts this by ordinance. And so when you put that on a map, what that means is this is the populous parts of the state. It's Northern Virginia, it's the central Richmond area, it's Hampton Roads, and I'll give you a local example. I think the folks in Goochland would like very much to have the option to do some things at West Creek. So there's a pathway for this. And with this, what we do in the bill is we basically take the COPN process out from that area and go to the permitting process. And I think the permitting process is very much like last year's as far as the obligations. And I assure everybody it's got a quality piece, it's got the charity care piece, and the charity care definition. It deregulates.
Mr. Chairman, and on that very point, it also, in the case of Goochland, would require active involvement by the elected officials in that jurisdiction, pass an ordinance to want to participate. So you bring in community involvement at that.
Correct,
point.
sir. And now I've lost my train of thought.
I'm sorry. I was afraid I'd lose the question.
So I just want to assure everybody that the charity care piece is there, that the quality piece is there, that the modern equipment piece is there, that somebody can't get an old scanner. So I hope folks, maybe in contrast to last year, folks will actually take time to read the details of that bill and understand that it's got good safeguards and protections in it. And I appreciate that Delegate Stolley looking at that permitting process in his bill. This bill also does a broader job of deregulating things like hospital beds and capital projects. And I guess the other big piece that it does is it does deregulate imaging in those areas in the second year. So this sort of is an alternative with a somewhat similar process, but a little more robust, but it does have a soft landing because it does it in 2 years. Sarah, what else did I miss?
How much do you know?
What?
That is the primary high points.
So that's it. Are you glad to answer the question?
Thank you, Delegate O'Bannon. Questions from the subcommittee?
Thank you, Mr. Chairman. So, Doug, I've seen the map in my particular district. It's got Lynchburg sort of darkened and the surrounding counties. How would you envision they would be affected by this?
Well, I think that depends on the level of competition and who might be interested in trying to get out of the COPN process and go to alternate route in these localities.
Okay. Thank you, Mr. Chairman.
Laura.
fair to say that compared to last year's measure, this is basically, for lack of a better way to put it, potentially establishing what we call a pilot based on high-density population areas where the population demographics, number of patients needed to be served are much different than anywhere else in the state.
Where there are a lot of populations of people, where there are multiple systems, where there's in fact competition, this would provide. I'm coming at this from my constituents, and I think that the world is changing and that we need to have more options in healthcare. And I'm not interested in hurting hospitals at all, but I think this provides a mechanism where we can get the opportunity to have things done a little more efficiently and a little less expensively. And I want to make this point, anytime this comes out from COPN, there will be very strict charity care requirements equal to whatever is done in that area. And so it's not cherry picking. And I'm glad to answer your questions, and I'm sure you'll have public comment or anything.
Further questions from the subcommittee members?
Thank you, Mr. Chairman. How would this impact hospitals in my district ability to break even financially with this financial impact, especially at ER, what we hear right now is some of this transition really impacts the negative.
Yeah, so there is actually a lot of data on hospital financial status. The vast majority of hospitals in the state are financially stable. There are a few that are not, most of those in the rural areas. So I'm just reminding you that many of these hospitals who do enjoy a nonprofit status get some benefit from that, and so they do have some obligation to the community.
Thank you.
Anyone in the audience wish to speak to the bill?
Mr. Chairman, members of the subcommittee, also came with the coalition to support COPN reform. We are in support of this legislation. We appreciate the patron for incorporating a variety of components that we find very integral to the physician community, including accreditation, registration, a strict charity care requirement. Thank you.
Thank you.
Mr. Chairman, members of the committee, Brad Marley, Virginia Hospital and Healthcare Association. I'd like to thank Delegate O'Bannon for his work on this bill and the creative approach that he's taken. We do have some concerns. Haven't had a close chance to look at the innovation zone concept yet. On first blush, in terms of what we're hearing, the concerns I think we would have most immediately would be how this would affect the Commonwealth in terms of one locality versus a neighboring locality that's either in or out. And when you think about charity care in particular, a very important piece of this, how in-depth are these charity care provisions with respect to as I read this today, it replicates the current charity care requirements under the law, which would allow a new entrant into the market to fulfill his or her charity care condition by writing a check to the Commonwealth. It doesn't obligate that individual to accept financial assistance. It doesn't obligate that individual to accept Medicaid patients or Medicare patients. If they fail to comply, they always have the option to write a check to the Commonwealth. And if we're talking about expanding access to these deregulated services, there ought to be the availability of those deregulated services for individuals, regardless of their ability to pay, in a fashion that's different than what's set forth in the current charity care requirements under COPN. The other concern we would have with this, in terms of how it affects the outlying areas, if you have an innovation zone, you've got the ability of the individuals in that innovation zone to essentially block others in the area from expanding. You've got individuals leaving one locality, going into another. That takes patients, that takes workers, that takes jobs. And what would the effect be on the neighbors? And how would that play out? And I think that while, again, the concept of innovation and the pilot approach is much appreciated, we're concerned about how this would affect localities and potentially setting off some unintended consequences that are not the best policy for the Commonwealth.
Thank you.
Mr. Chair, members of the committee, Jill Henkin from the Virginia Poverty Law Center. set above current levels in the region. That's a very limiting requirement right now, and whoever reviews the certificate or permit should be able to increase the amount of charity care required. Number three, it was just mentioned that recipients of certificates or permits can simply write a check to the Commonwealth. I don't think we should make it that easy. I think the need is to get services to people who can't afford it, and by writing a check, you really can undermine that obligation. And finally, you'll notice the penalty for non-compliance with a condition is just $100 per day. I think that's pretty small compared to the size of these projects. So I don't know what the right number is, but I think $100 a day is again, not stringent enough to enforce these obligations. Thank you.
Thank you.
Well, I appreciate everybody's comments, and I'm just kind of reviewing this processing here that the commissioner has, and I think current law doesn't have a penalty. It has a penalty, but it hasn't been enforced, or almost rarely enforced. So that's something I'm very happy to think about going forward. My hope is that all these bills will get out of the House and go to the Senate, and certainly as some other folks have pledged, we'd be glad to sit down with folks and look at ways to try to refine this and get more stakeholders comfortable, particularly Mr. Rawls and his folks. I will say this, that the bill does have the same thing it did last year for things. This is not a repeal bill. This is a reform bill. And so transplant services and a variety of other things that are important to have good volume, like mixed use and open heart, clearly are volume-based when they come out. So that's the bill and we're committed to.
Thank you. Anyone else in the audience wish to speak to the bill? Are there further questions from the subcommittee?
Mr. Chairman.
Eleonora.
Not a question, a comment and a motion. The joint committee that met on this in the fall and going into it, we laid out certain objectives, and I think anyone who was here last year would say tonight, I think we're at a very different point from where we were last year. That last year we did try to resolve it all and come out with one omnibus bill. And I think, Mr. Chairman, and the audience would have to agree at this juncture, the committee is taking a much more broad-minded approach, shall we say, that we are embracing a number of potential solutions. But I think there's one clear message that, at least in my motions and my votes, are reflected. We need to reform the process. And Delegate Stolle and Delegate O'Bannon, both in particular, both comprehensive bills, have proposed this year some significant difference in their measures from what we saw last year. And so I hope, after 40 years, we're finally moving in a direction where the industry will be able to come together with us to effect a process that will be in the best public interest. And so with that, Mr. Chairman, I would move that we recommend reporting House Bill 2337.
Second, as amended.
Mr. Chair, we have not adopted the substitute.
Oh, never mind.
Mr. Chairman, I move forward.
Keep us straight.
Delegate Garrett has moved to accept the substitute. We have a second. Without objection, the substitute is accepted. Now I'll entertain your motion.
So moved.
Second.
Moved and seconded to report the bill, and I'll just echo Chairman O'Rourke's remarks and thank everyone for their diligence and their willingness, especially Delegate Stolle and Delegate O'Bannon. You've done a lot of work. I know a lot of people there than I did last year this time. So hopefully we're on the right track here. Having said that, all in favor of reporting the bill, please say aye.
Aye.
Any opposed? The bill reports.
Mr. Chairman.
Eleonora.
If I may, before we take up the next measure, since we probably have most of the interested stakeholders in here, these will be on the docket Tuesday morning. In keeping with my normal practice, we will not have a rehearing of the measures. If any stakeholders have new or different information or folks who are unable to be here this evening have something to share with us, they'll be afforded that opportunity Tuesday, but they'll be going to the full committee with recommendations to report.
Thank you. That completes our first block, COPN block. We will move to block 2.
Now we can meet in your office, Mr. Chairman.
Got yourself one. Hey. Finally, I know. Okay.
So what is next on this rezone process? Are you done with the COPN part?
Yeah, finally. Been here for 2.5 hours. Check it out.
I'm ready.
We got plenty of things ready.
Just throw them out. OTD, guys.
Josh, are you going to sit down? Okay. And there's 2. Right? Are you good?
Are there other members?
I'm just asking what? Getting our
What point am I in?
I don't know if they have the list. Fourth on this list. All right, this is my 5th bill this afternoon.
I had at least that many died. Erica? So I say, Mr. Chairman, I have an amendment in the nature of a substitute. ask us to move it.
We are ready to resume the meeting with our second block. Just waiting
This is my
for
explanation.
Sarah to get
Where
back.
is it?
The necessary. Okay, I have assigned this list, I'm going to write down the list if they're here. We'll take them in that order. If not, we'll skip past them and take the next one. And first up on this list is Delegate Lingenthal.
Mr. Chairman, I will speak to his, but I'll do that after we've gotten all patrons who are here.
Thank you.
Laura. Next is Delegate Lopez.
Are you on this?
House Bill 1863.
Good afternoon or good evening, Mr. Chairman.
Good morning.
Good morning.
Not quite yet.
HB 1863 has to do with viewing TANF benefits, hardship exception transparency. Basically, this legislation is about transparency and accountability. As many of you know, under Virginia Code 63.2612, view participants and their families may receive TANF benefits for a maximum of 24 consecutive months. However, there's a hardship exception to this 24-month limit, which includes 4 options for those who need an exception. 1, a view participant who has been actively seeking employment by engaging in the required job-seeking activities but is unable to find employment. 2, factors relating to a job availability may be unfavorable. 3, the view participant loses his job as a result of factors not related to his job performance. And 4, extension of benefits for up to 1 year will enable a participant to complete employment-related education or training. Earlier this year, I reached out to the department to learn more about how many individuals received this exception and what their reason is for requesting it. I was surprised to learn that this information is not currently tracked by the Department of Social Services, and there was no data point for them to provide this information. This legislation remedies this problem by requiring that the department keep track of the number of view participants who receive an exception to the time limitations for TANF benefits due to hardship and the specific circumstances relied upon to grant such an exception. The bill also requires the department annually publish non-identifying statistics regarding such information. Again, this legislation is about transparency and accountability. Regardless of your views on the VIEW program and the TANF benefit program, if we want to know how the 24-month time limit and hardship exceptions are functioning, we need to be able to identify how many people are using this exception and why they are needing a hardship exception in the first place. There is a one-time fiscal impact to update the current system of $164,000 in FY 2018, but this is a non-general fund money, and that would come from the current TANF block grant surplus that we have. That, Mr. Chairman, is the bill.
Thank you, Delegate Lopez. Are there questions for the patron of the subcommittee?
So, Mr. Chairman, even though it's non-general fund, that's still a moving part, I think, and up on the ninth floor about what we're going to ultimately do with the TANF balances. And I don't think that's actually, we're sort of beginning those conversations. I don't think we're far down that path. So
I get it. Mr. Chairman.
Laura.
Delegate Lopez, given that all of this is working under the federal provisions, what is the state benefit of gathering this data? What do we get out of it?
For one, we'd like to be able to find out the information so that we can track, and having more data is better than not having data. And if the program is working, let's know if the program is working. If the program is not working, let's have the data to be able to tweak it and fix it.
Okay.
Further questions from the subcommittee? Hearing none. Anyone in the audience wish to speak for or against?
Come on up. Yeah.
Our camera over there. Mr. Chairman.
Laura.
I have a motion. I move lay on the table.
Second.
Moved and seconded to lay the bill on the table. It's not debatable. All those in favor, please say aye.
Aye.
Opposed?
No.
The bill is laid on the table.
I appreciate that. I'll be interested in having a conversation as to why you're opposed to these bills, but we'll talk later. Thanks.
according to state standards. The only thing more stringent would be the county's power related to future construction.
Yes.
And abandonment.
Yes, that's correct.
But if I'm understanding, the problem is with existing.
Yeah, that,
Well.
but they want to try to avoid repeating the problems that they're currently experiencing or had in the past. And some of them think that they can, this would better enable them to, whenever development goes in, it's going to be a well and septic to require additional testing to make sure that there's going to be sufficient water there.
But I don't see how that gives them anything greater than what the state currently does because it relates to construction. My understanding would be a requirement of additional grouting, potentially a wider well curving, things of that nature. Okay.
Further questions for the patron? Anyone in the audience wish to speak to the bill?
Good evening, Mr. Chairman. I'm Mike Olson with the Home Builders Association of Virginia, and among the groups I represent is the Fredericksburg Area Builders Association, who opposed this measure. We're opposed to it for several reasons. Most importantly, it complicates maybe where the location of the house will be. While it says that you have to have testing standards of water, I think you need to understand what that means is you have to drill the well so you can test the water. The effect of this bill is you would have to drill the well before we begin construction of the house. And what that does for our industry is a couple things. It really complicates separation distances, because typically if you're drilling a well in rural Virginia or those areas not served by water and sewer, you have to have locate your well 100 feet from where you're going to locate your septic system. You have to locate your well 50 feet from where you're going to build your house because of the chemicals used or required termite treatments. Typically, the well is drilled much long after where you decided to site your house. You put it first, you get your greenhouse, your dig location. The next phase is where are the suitable soils for you to be able to have your appropriate septic system. And third, you look for the site for your well. By requiring the well first, it really complicates that process. And most importantly, by requiring to have a well drilled first, it really complicates the question of who's going to pay for the well. Because typically a builder only gets a draw after there's a lot. So the lot hadn't been drilled, hadn't been cleared. The well driller was trying to get into the property. So the lot has to be cleared. You have to get access from VDOT to where your driveway is going to be located if you're not in the subdivision. Immediately you're not. And then you've got to pay for the well. Typically the well is $12,000 to $15,000, however deep you go. And the well driller has to be paid. Since that becomes so early in the process, it's best that it comes later in the construction process. Thank you very much.
Thanks, sir.
Mr. Chairman,
Yes, sir.
members of the committee, Jeff Gregson on behalf of the Virginia Water Well Association. I can't really add a lot to what Mike has said. I might add that one thing, that you all are probably familiar with the Eastern Virginia Groundwater Management Study, which is ongoing and is going to conclude sometime this spring. I think there's a high likelihood in Stafford County, a big chunk of it is in that Eastern Virginia area, groundwater management area, and they're likely, that study is likely to come with some regulations, additional regulations on the water wells, so we might be at, Doug Cole said there was only a few problems, and I think to give the county sort of carte blanche and complete control idea is what they want over all water wells in the county. It does seem a bit extreme, so I hope you will not support it.
Maybe sum up, Mr. Chairman? Yeah, just to sum up, actually, Mr. Tolson's has made my case for me, and that, if you're going to have well problems, it's better to find out before you build the house and then not after the house. That's what we have with a few families in Stafford, where this couple with a family have built their home, and they drilled 3 wells on the property, spent about $50,000 trying to find one that will provide a sufficient water supply for the home, and they can't find it. And so that's what my bill is trying to avoid, future recurrence of a situation like
study area, so it will not be impacted by the eastern study. So anyways, that's you know, I've made my case. I think it's a reasonable bill that will help to avoid future problems. Granted, it's not going to be the fix for those who are currently experiencing problems, but I think it's a reasonable step.
Thank you, Dr. Cole. Are there further questions or comments from the subcommittee?
Mr. Chairman, I'm just curious, I don't know if Michael, if you're the right one to ask. So how often is it that we will, you know, get a permit, develop out an area, build on it, begin to build on, to the delegate Cole's point, build on a bunch of lots, and then you find out the land doesn't perk, which I guess should have been tested beforehand, or you drill and there isn't no water to the delegate's point. I realize it happened with this one family, and I truly get it, and Delegate Cole, I sincerely appreciate your advocacy, sir, and I say that with
I think in those localities that have this, in those localities that have this ability to require it, there's a widespread pattern of difficulty finding water. They always find water. When you ask the well driller, like Greg can answer the question, Jeff can answer the question, you say, what do? You just keep drilling. You drill until you get the quality of water you want, either through storage or through the depths of the well. You always find water. You just have to keep drilling. If they drilled 3 wells, it's a pretty large site. I understood there was one problem that's been developed. Like I said, if it was a wide pattern, the industry would be here and wouldn't be opposed to this. But we know of one issue where they struggle to find water.
Thank you. Thank you, Mr. Chairman.
Mr. Chairman?
Dr. Van.
So it's not my area of expertise, but I think the delegate has constituents might have a problem. My concern is that we're better off to do things by policy rather than Christmas tree and add individual ones and move them down the table.
Moved and seconded to table the bill. That is not tabled. All those in favor, please say aye. Aye. Opposed?
Thank you.
Thank you, Delegate Cole. Delegate Watts.
It's Bill 2061, and I have a just explaining the handout, this came from the annual report that's put out by the Department of Aging and Rehabilitative Services as far as the data that is routinely done every year, so that you have a perspective about the bill, which is requiring that the data be produced on an annual basis and available to the published by the Department of Aging and Rehabilitative Services, and is available then to the Department of Health and to all local boards and social services and area agencies on aging. It's been a long day. And in that data, what would be categorized by planning district in which the report was filed, the facility in which the abused, neglected, or exploited adult resided at the time of the abuse, the neglect and abuse, neglect, or exploitation, if applicable, and the names of individuals who were subject to criminal charges. And the reason for the bill coming before you, and you also then, as far as the substance of the first page of what I passed out, please note that of the reports that are investigated, 55% are substantiated, but of that substantiated, please look down and see that need no longer exists. 40% of those that are substantiated, need no longer exists, essentially means that in most cases, the individual has died. And so that the pattern of
where these incidents are occurring, I believe is important to fulfilling the mission of the area agencies on aging, as well as the local Department of Social Services, as well as that aggregate to the degree that it is not requested by a licensure and inspection, certainly should be. If I can say one more word, again, I have a long involvement in the issue of abuse, and fairly recently, elder abuse. The long involvement in abuse was 7 years working with the severe cases of child abuse and neglect coming for the CASA program in Fairfax County, with approximately 300 to 400 cases every year. What happens with child abuse is that you have a long-term advocacy of people who have been affected by it. Oftentimes have been in the foster care system. There's all kinds of reasons why the advocacy goes on and on. When it comes to domestic abuse, we also require similar data be published for domestic abuse. But what happens when it's elder abuse? All too often, once the individual has passed, that chapter is closed in people's lives, and we don't have the ongoing both advocacy and awareness, so that I felt that this data being in the hands of the area agencies on aging, aggregated as I had indicated in the legislation, would be very good preventative, and the rest of the pages that I have included from the annual report indicates that all of this data is collected. You've got it by county, you've got it by planning district, you've got it by type of facility where it may have occurred. And so it's just a matter of re-aggregating it and putting it in the hands of people who have a need to know to fulfill their proper mission in prevention.
KDW wants questions for the patron.
Thank you. But Vivian, why can't the Rappahannock Area Agency on Aging look at this data right now? And why can't they, if need be, if they need more information, reach out to the agency?
And that becomes the issue. Reaching out to the agency, you're still doing it on a spot-by-spot basis as to whether or not the growth or change over a given year is significant, or whether or not there's a grouping of that report. And so, again, what I believe is important for all area agencies on aging or commission on aging is to have this kind of data so that they can look in a preventative way as to whether or not there appears in their purview areas where they need to take a closer look on a prevention basis. That simply having it as a county aggregate doesn't fulfill that purpose, nor does it aggregate it then as far as the type of, whether it was in a facility or in a home or where it may have occurred. It's just gross numbers of abuse of all types of cases and all types of settings.
Thank you, Mr. Chairman. Part of my question was Delegate Borax, and the second part, so the language says the department's going to keep records of alleged, suspected abuse, and they're also going to keep the names of individuals who were subject of these charges as a result of investigation. So,
Substantiated charges.
I don't see that concept here.
And the names of individuals who were the subject of criminal charges as a result of the investigation. So it's not until you actually felt that you have a fact pattern where you would go forward with a criminal charge, which is actually very rare.
But I guess, Mr. Chairman, my inference, and I have to defer to counsel if that's what it actually says, or my layperson's reading of this is, if, my wife alleged that I, abused her, and we're both elderly, because I'm getting there quickly, and as the moments go by, even quicker. If she alleged that I abused her, now the department's going to collate that alleged suspected abuse, and the department's going to have to give out publicly the name of me, who I really didn't abuse. No, okay.
As long as the bill shows, this would only be in cases in which you have criminal charges. So we've gone through the
it's not a conviction, it is the person who has been charged with the crimes associated with the abuse or neglect.
And then, Mr. Chairman, just follow up. So,
Sarah, back to my first question. Again, if my wife alleges that I abused her, that would now all be a reportable thing? I'm getting a no from you and a yes from your legal counterpart.
If you were charged.
Right, if you were charged.
If the department thought it was sufficient to charge you. But you could be acquitted subsequently through a court proceedings.
And not,
Mr. Chairman, I'm not trying to belabor it, but maybe they'll go to Argo. You can help me because I understand or I speak.
Well, Mr. Chairman, if I understand, this is where the department felt it rose to the level of them being charged, and a court proceeding was entered into. Now, it doesn't mean that you were convicted. So it could be an individual that then was acquitted through a court proceeding, but the department had felt that it was reasonable enough evidence for criminal charges to proceed, and the Commonwealth's attorney concurred.
And, Mr. Chairman, that's 45% of the time?
No, sir.
But it says 55% of the reports are substantiated.
Yes, that's part of the reason why I was also inappropriately trying to break in. That the mission of the department is to take a person out of harm.
Sure.
So when they talk about substantiated, they mean that people need help. People need to be moved. People need to get out of a setting. People may be in severe depression and not eating, etc. That is what substantiated means. The individual needs help. But the actual filing of criminal charges is extremely rare and would involve a police and law enforcement investigation before you could go before the magistrate, the judge, and actually get a filing of charges. So totally different universes.
And I think, Mr. Chairman, and I apologize for intruding on the committee's time. I know it's late in the day. So since it's extremely rare to get down to that point, it sounds like it's going to be extremely rare. You're going to have a bunch of people who we're going to now require the department to keep those names of that extremely rare numbers of cases.
And yet we have our criminal records checks. Whenever we employ somebody, we're looking at the criminal record check. We're looking at, in the case of child abuse, whether or not there's ever been charges filed. So it is of that parallel, if you will, because these individuals, rare as they may be, they can cause a great deal of harm in their predatory, opportunistic behavior.
Further questions from the subcommittee? Hearing none. Anyone in the audience wish to speak to the bill?
Question or maybe a comment. It does have a fiscal impact, so general funds.
And it has both a dollar amount, which I'm not quite sure where that comes from, given all the data that's there, but even in the fiscal impact statement, the line almost below it says that it's minimal. Got too much paper.
They justify by saying they feel that the halftime FTE in order to administer.
Even with all the data that the line at the bottom of the first page says, therefore no significant fiscal impact is expected with implementing these provisions, because all this data is collected but just not aggregated in this particular way.
I'll just, Chairman Jones watches his pennies, and if we act on this, you may get a lot of it. Come on. So I don't want to, I'm not trying to.
Mr. Chairman, I don't disagree with the gentlelady's intent, but it frankly sounds like, one, because of some of the financial questions that arise, and secondly, I have some hesitancy, even though these are individuals who were charged, their names are being put out there and they have not been convicted. So I'll just move it and lay on the table.
I'm sorry, Mr. Motion.
I moved to lay.
I would second that, Mr. Chairman.
Moved and seconded to lay the bill on the table. All those in favor, please say aye.
Aye.
Opposed?
find out early.
We'll stay here. We'll stay here.
Delegate Marshall.
Oh, no. Couldn't I go before him, because he's gonna take a long time, and I'm gonna take 2 minutes.
Did you have a copy of this? You might want. Mr. Chairman, before the patron presents, I'm going to move the adoption of amendment made to
Can I ask
substitute.
him if I can go before him?
Second. You want to pass it? And I'll probably amend this more because that's what I'm so wanting to do on that.
We have a motion and a second to amend this bill in the nature of a substitute. All those in favor, please say aye.
Aye.
Opposed? Okay, substitute's accepted. Doug Marshall.
Okay.
Oh, no. We've kept the premise of your bill about pornography being a major problem.
Right, yeah, okay, all right. Mr. Chairman and members of the committee, House Joint Resolution 549 seeks to secure a recognition from the Virginia General Assembly that pornography is a public health problem both for individuals and for society. If you look at the behavioral research in this area, you will find, for instance, Malmuth and Dannerstein in 1983 and Zillman and Bryant in 1982, where males were exposed to 6 weeks worth of standard hardcore pornography for about 4 hours and 45 minutes. The attitude that they developed later on is trivialization towards rape, which means that after 6 weeks of exposure, male subjects are less likely to convict for rape, less likely to give a harsh sentence to a rapist if in fact there's conviction. So what this would tell a prosecutor is if you have a trial for sexual assault, you would not want to have individuals who habitually view pornography in the jury because they would be less likely to convict and less likely to convict for a long sentence. So both of these studies led to that same conclusion. Another study of males, college students, were divided into 2 groups. One group saw pornographic video, the other group saw non-sexual video. Both were told that they're going to be interviewed by young women about a student experience transferred from high school to college, but it was a female research assistant. The female research assistant did not know of the subject's exposure, which males were subjected to exposure to pornography. Very interesting. The assistant was supposed to record on her notes the male's subject apparent sexual interest in her and note how close the subject placed his chair to hers. Uniformly, the women who were doing the interviews found that the men who viewed pornography placed their chair much closer to her than the guys who just watched the educational film. When the men were interviewed, the porn prime men were asked questions about the physical appearance of the women. The men who viewed the pornography films were much more adept at describing sexual aspects of the woman who was interviewing them. The others were in the ozone. They just were not clued in on this at all. Furthermore, exposure to pornography does not have its harmful effects just from pornography that is violent. Zillman and Weaver concluded, and this was the book, Men's Exposure to Pornography and Callousness Towards Women, 1989. It says, exposure to pornography influences the perception of women in sexual terms, making them appear more permissive and promiscuous than they actually are. It is the powerful effect of exposure to nymphomania in the condition of female-instigated sex, however, that is most damaging to the claim that all is due to violence. This condition is characterized by the total absence of coercive or violent action. It nonetheless produces the strongest trivialization of rape overall. Now, in March of 2010, Nielsen, the TV rating agency, surveyed Americans on pornography viewing at work. It was a very interesting finding. This was at the time that the Securities and Exchange Commission discovered that a bunch of their people, instead of watching the stock markets, were watching something else. They were fired. Nielsen Company reported that more than 21 million Americans access adult websites on work computers in March 2010. That's 29% of the workforce of the United States. That is a catastrophic waste of public resources. Remember in 2002, VDOT had to fire 17 employees because instead of the VDOT employees helping citizens negotiating their way out of traffic, they were trafficking in pornography. Mr. Chairman, Laura Vazella did an article about the bill that I introduced here, and she asked me, why did you need to make this declaration? And I likened it to the circumstance of U.S. Surgeon General Luther Terry, who in 1964 came out with the first federal government report linking cigarettes to disease. Until we did that, there was no focus in the public arena, and especially the federal government, on the harm or the harms that would be derived from smoking cigarettes. Now my resolution picked the interest of Senator Barbara Favola, and she and I have some policy differences occasionally. Quote, we will talk about it. Laura Vazella asked her about the resolution. This is what Senator Favola said. We will talk about it in the Women's Health Caucus. I am sure of that. She said, he's right. Pornography does have a negative impact on public health, and it does lead to lots of other issues. I am going to look at it. I have some letters here. I won't bother reading all of them from a wife in Roanoke, well, and actually Hollins, Virginia, talking about the fact that her husband is ensnared by this. He's gone to counseling, 12-step program. My spouse continues to pursue his addiction. I don't know what the future of our marriage may be. She talked about the neurobiological effect of the dopamine that is released, similar to cocaine, heroin, and other substance compounds that's associated with pornography addiction. Pornography addiction affects trust among married couples. Only 14% of a married partner report that they trust their spouses after the addiction has been discovered. That's 86% do not trust them. And only 52% were interested in sexual relations with the addicted spouse. So I'm going to stop right here, Mr. Chairman. I do have witnesses who come down from Washington, as well as some people around here. But I would take questions about this first, if that's your pleasure.
Questions for the baker?
Mr. Chairman, before we go to witnesses, it would be proper to kind of get us in a posture. We've adopted the substitute. Just explain kind of what the substitute says, possibly different from what those speakers coming forward might be speaking to.
I think that's appropriate.
And Mr. Chairman, I'm just saying the substitute we've adopted keeps what I think is the spirit of Delegate Marshall's bill. What we have done is taken out references declaring it a public health hazard, because as a matter of policy, we as a body politic do not make such determinations, but rather leave that to our trained medical community to make that determination. Secondly, in the initial draft, it was rather gender specific. The pornography was something only involving women and children. We've taken out those gender references because there's male pornography as well, which can be just as harmful. So we made the document gender neutral in all respects. And that's the main differences, I believe, from what the gentleman had introduced. There are a few grammatical changes that I'll propose after we've heard the public testimony, Mr. Chairman, but I think that's kind of where we are and yes, what we have before us.
Mr. Chairman,
I just would say, from a cursory look, it seems you kept all the substance of the whereas clauses.
Yeah.
You said it's a problem, individuals and social, just
Right.
don't say it's a public health problem.
Right. Pretty much.
Everything else is the same, with the exception of gender.
So, Mr. Chairman, that was in fact my question. This would, if adopted, would clearly put the General Assembly on record as recognizing that pornography leads to individual and societal harm. The General Assembly recognizes the need for education, prevention, research, and policy changes at the community and societal level.
Right.
Is that correct?
Yeah. Okay. All right.
Dr. Marshall, let's hear from your witnesses.
Judy Reed would like to testify. She's Jack Reed's wife. Yes, sir.
Point of personal privilege.
Yeah, man.
I want to welcome Judy Reed, but also want to acknowledge your other half, Jack Reed, who served here with us for a lot of years. So
encouraged to consider passing HJ 549, even in its amended form, and declaring pornography a public health hazard in Virginia, similar to the boldness of Utah. I'm 73 years old. As a young girl, my major exposure to pornography was in the darkness of a private car at a drive-in movie. Emotionally and physically, I was in crisis. Low self-esteem, images permanently embedded in my mind, and lack of trust harshly affected my development and my view of life growing up. For over 50 years, I've watched, like an eagle, the escalation of pornography in the culture and invasion into our homes and families. I've seen it destroy marriages and relationships. Andrea, a wife and mother from another state, committed suicide rather than tolerate her pastor husband's silent porn addiction. No one was willing to talk about it or seek help. From personal surveys, individual stories, and simply observations, the statistics in the accompanying report from the National Center on Sexual Exploitation are supportive of a reality none of us want to be truth, but they are. As an advocate for the respect and dignity of women, I would so like for you to take the first step of awareness, a major one really, and pass HJ 549. Again, I sincerely thank you.
Thank you, Ms. Baker.
Mr. Chairman, I've got the witnesses. Doug Marshall, thanks. Haley Talberson. She's the Director of Communications for the National Center on Sexual Exploitation.
Hello, my name is Haley Halverson, and as Dr. Marshall was so kind to mention, I work at the National Center on Sexual Exploitation, a nonpartisan nonprofit located in Washington, D.C., dedicated to addressing the harms of all forms of sexual exploitation. The term public health crisis is used broadly to define physical and social harms, from smoking cigarettes to bullying, and it unequivocally applies to pornography because pornography is serious harm that is damaging to individuals and groups beyond their capacity alone to correct. Recently, a concerned mother called our office to tell the story about how she and her daughter were exposed unintentionally to pornography online while they were simply looking for American Girl doll, child-appropriate video games online. This mother was doing everything right. She was monitoring her child's online activity, looking for child-appropriate content, and yet still they were exposed to pornography. This goes to show how pervasive pornography is in our society today. In fact, a recent survey found that 27% of young people were first exposed to pornography before they had even reached puberty. Like other public health issues, not everyone who is exposed is experiencing the same effects. However, for many, repeat exposure and use of pornography is linked to a multitude of harms, which are listed in part in the booklets which I've provided for you. We have over 80 peer-reviewed research summaries, articles that are summarized. And today I will speak briefly on the way that pornography impacts the brain, the body, and rates of sexual violence in our society today. As far as the brain goes, since 2009, there have been 24 major studies that reveal the reality of compulsive porn use and the way that pornography negatively impacts the brain's structure and function. A 2014 study found that increased pornography use is linked to decreased brain matter in regions associated with motivation and decision making, and the shrinkage was more pronounced in users that were the heaviest users. Compulsive porn users' brains light up in the pleasure centers similar to cocaine addicts when shown activity-specific cues. And this is a hallmark of any addiction or compulsive use. Regarding the body, pornography use is linked to
negative body image among men and women alike. And as well as pornography is also linked to increased activities that increase the risk of sexually transmitted diseases, such as having sex with multiple partners, engaging in paid sex, and having extramarital affairs. Pornography use is also linked to decreased erectile function. A 2014 study of young men found that pornography use was linked to lower overall sexual satisfaction with their partners and with lower erectile function. Pornography is sex negative. Wiring your brain to pixels on a screen rather than a real person is the antithesis of healthy sexuality. Regarding sexual violence, pornography shapes the user's sexual template around themes of degradation, unclear consent, and violence. Analysis has shown that the majority of pornography reveals physical and verbal violence against women, and in those acts, 95% of the women respond in pornography with expressions of neutrality or pleasure. Pornography is literally teaching that women enjoy sexual violence. The Playboy of the past is no longer what people are consuming online. Tragically, the messages that pornography sends are now being heard loud and clear. A meta-analysis of 46 different studies reported that the effects of pornography are clear and consistent, in that they do put one at increased risk for committing sexual offenses, along with believing rape myths, such as the beliefs that rapists can't control their urges or that women enjoy rape. Is this the kind of sexual education that we want in America? Today, pornography is pervasive and it is damaging countless lives. But the same can be said of cigarettes and the tobacco industry in the 1950s. But as we learned through experience, a public health model that unites a willing government, concerned citizens, and health officials has the ability to greatly reduce the impact of a toxic industry. Today, there is something tangible and meaningful that you can do in order to combat these harms. I implore you to move this resolution forward, to follow on the heels of Utah, which passed this very similar resolution unanimously, had a ceremonial signing, in fact, on it, and on the coattails as well of Canada, which has passed a similar resolution which calls for further research on a national scale. And so I ask that you move this resolution forward on behalf of women and children and men in the hopes that future generations will be better safeguarded. Thank you.
Thank you. Dr. Vance.
We've got a lot of interest about substance abuse and addictions because of our opiates. Is there any data that pornography is genetic or hereditary, or that there's the same circumstance exists in this addiction as in those others?
There has not been any study on hereditary, although that would be a really interesting study. But there have been a lot of studies showing that the same neurons that are firing with opiates, with heroin, are the same with pornography.
Right.
Thank you. Further questions from the subcommittee? Thank you very much.
Thank you so much. I'd like to have Savannah Lawrence, also from the National Center for Sexual Exploitation. She's an attorney.
Yes, Mr. Chairman, and love to hear the presenters. I would just ask if there's a way, given the lateness of the hour, and we've still got another 4 or 5 bills, if the presenters, when they come forward, can share different information, because I think we're about to act favorably.
Okay, all right.
So, good evening. As Delegate Marshall indicated, my name is Savannah Lawrence. I'm a legal fellow at the National Center on Sexual Exploitation. As you heard from my colleague earlier, just a moment ago, pornography is a public health crisis. It impacts families and individuals throughout the United States, and most specifically in the state of Virginia. Today, I will be testifying on the harms of pornography with its connection to sexual violence and sex trafficking. It's no secret that in the state of Virginia and throughout the United States, there is not an area that is immune to the abundance of sexual violence and sex trafficking that is sweeping our nation. One only need look at recent news articles and headlines to see the effects that pornography is having on our public. We have campus assault issues all throughout the United States, including this state as well, with issues with Virginia University being, the University of Virginia being under a lot of critical skepticism on their issues of sexual assault, as well as
With all of these reports and with the many unreported cases, the public is left to wonder why this is happening. And while there are many factors associated with sexual violence and coercion, the research shows that pornography has a significant correlation to these issues. First, pornography has a drastic effect on children and their proclivity to sexual victimization. In the United States, a study was done on youth from ages 9 to 17 that found that those who looked at internet pornography were significantly more likely to report physical and sexual victimization. When children are exposed to pornography, they are more likely to become sexual predators. Pornography exposure also affects adults' attitudes and behaviors. A study on college-aged men found that when men view pornography, no matter what type, they were all significantly more likely to indicate a willingness to commit sexual assault than men who choose not to view pornography. This proclivity to sexual assault also affects the home. A study found that the use of pornography by batters significantly increased a battered woman's odds of being sexually abused. Moreover, pornography is also closely associated with sex trafficking. By federal standard, sex trafficking is defined as a commercial sex act induced by force, fraud, or coercion. In 2007, a porn producer was convicted of sex trafficking. He ran a torture porn site and psychologically coerced a victim to engage in heinous torture pornography. This legal decision reflects a deepening understanding of the ways in which pornography, prostitution, and trafficking are all the same for the person who is being sexually coerced and exploited for profit. Moreover, we know that pornography leads viewers to engage in sex trafficking through the purchase of prostituted persons, many of whom are trafficked by pimps. The evidence I have discussed today is just a small sampling of the proof that shows that pornography is inherently connected to sexual violence. As my colleague indicated, we have passed out booklets that contain 80 peer-reviewed articles showing the correlations between pornography and various types of health-related issues, from violence to effects on the brain. And I would encourage you to consider looking at this as a public health crisis. It's more than just a problem. As my colleague indicated, states have recognized this as a public health crisis. The state of Utah, as well as the country of Canada in their Canadian Parliament. This is more than just a problem, and it's something that we need everyone to band together to fight against.
Thank you very much. Dr. Marshall, I think you're in a good place right now. Let me see if there's any opposition to the bill. Anyone wish to speak against this resolution?
Mr. Chairman, I have a series of other proposed amendments if I may too.
You're right.
Mr. Chairman, I would first propose on line 9 of the measure after program, strike the word must and insert should. On line 11, after the word pornography, strike is contributing and insert may contribute. On line 14, after the word children, strike are and insert can be. On line 17, after the word exposure, strike is leading and insert can lead. Line 20, after the word pornography, strike often serves and insert may serve. And beginning of line 21, strike the word shapes and insert the words may shape. And Mr. Chairman, members of the subcommittee, what these amendments would do is there was language in the original resolution that spoke in the term of absolutes and that all were exposed to and all had the same effects. This terminology, I think, is with the spirit of definitely a problem for many. But it's more reflective of what the actual data.
I have a question.
Yes, sir.
You're not proposing any amendments to the results?
No, but feel free. That's your.
No, I like the
Yeah,
results.
I did too.
So I don't know what's messing with those. I think the rest of it.
Yep. So I think if subcommittee's pleasure, we could act on those as a block. And I'll share this with Sarah in case you missed it. I talked slow enough.
I move the amendment. All right, second.
Mr. Chairman. Just a question for Agent Doug Marshall. Do you accept these as friendly amendments?
If it comes out of here with it on there, it's friendly to me.
Normalize it.
It isn't the car I drove in with.
But it does put the state
It
on.
gets me on the road.
It puts the
Yes.
General Assembly
It
on
puts
record.
us on record.
Yeah.
You have a good.
Mr. Chairman, if I could, Delegate Marshall, I mean nothing other than just, I'm hopeful that, and would ask you to be abiding by these. In other words, is it your intent that we would just get something out tonight and then tomorrow we're gonna see Bill A or something like this? I think the intention, Delegate Marshall, my read of this is just my inference, I think accomplishes what our conversation that you are about. And I can't imagine anybody believes that our families are perfect right now and that there isn't some fundamental challenges that are leading to dissolutional divides in many of our family structures. And this has changed our world today.
Quite a bit.
And I can't imagine that there are folks that would disagree. They may not like the reality of what it is that you're trying to accomplish, but I would hope that you would this would be congruent with you, sir.
If you stick with me, I'll stick with you.
We have a motion properly seconded to amend the substitute without objection. We'll accept those. Motion to report properly seconded. Any further discussion? Hearing none. All those in favor, please say aye.
Aye.
Opposed? Thank you, Delegate Marshall.
Thank you. This will be for the full.
Two. And generally, you won't need to be the subcommittee chairman will present the measure, just that for any questions.
Can you say it's unanimous?
No.
Okay. Thank you so much.
Delegate Rock.
Chairman, members of the committee, I will be brief. I'm here to present HB 2092, Department of Mental Assistance Services to use simple data tools to make sure welfare enrollees actually qualify. Calls for the department to use existing state and federal databases to verify enrollees' eligibility based on income, residency, employment status. Using existing state and federal databases is both time and cost effective. And I think it probably would be very safe to leave the rest of this details to somebody that or here with you to speak to this.
Okay, Delegate Rock, let's hear from Instruction Manager.
Chairman Bell, members of the committee, good afternoon, and thank you for the opportunity to speak today. My name is Greg Pfister, and I'm the Legislative Relations Director for the Foundation for Government Accountability. The FGA is a 501c3 nonpartisan organization. Our primary focus is on health and welfare policy, and we work with legislators from across the country in more than 36 states to help strengthen local communities and protect families, which is why I'm here today. I'd like to begin this afternoon by sharing the story of Jacob John. And Jacob was born with a rare developmental disability, and a condition so rare that only 17 people in the world suffer from it. At age 21, he's the oldest survivor. Jacob's condition caused frequent life-threatening seizures, leading neurologists on a desperate search to find medication to manage it. Only one name-brand drug has proven to be reliable at a cost of over $1,300 a month. Jacob was able to qualify for federal waiver assistance program through Medicaid to receive this medication. Everything was fine until the state of Illinois abruptly declared that it no longer had enough money in the Medicaid program and eliminated payments for Jacob's life-saving medicine, leaving the Chalkies desperately searching for answers. Unfortunately, this story is not an outlier. In Illinois, 752 people have died in the last 3 years while waiting for services that the state said they needed, but could not afford. And while the state left these families scrambling for answers, audits revealed that over 1,400 dead people were on the Illinois Medicaid rolls, and $12 million in improper payments had been made to enrollees who had died years earlier. A similar story can be found in Arkansas with the case of Chloe Jones. Chloe is a 16-year-old girl with cystic fibrosis and depends on medication that her family can't afford. Without her medicine, the doctor says that she won't live to the age of 50. Chloe has received vital treatments through Medicaid until the state decided that it was too expensive and stopped paying for it. Like with Illinois, in Arkansas, 79 people died in the last 3 years waiting for services that the state said that they needed but couldn't afford. While Chloe and her fellow Arkansans were denied services and medication required to survive, an audit revealed that nearly 5,000 people in Arkansas's Medicaid expansion rolls, approximately 3% of the overall enrollment, were discovered to be ineligible for the benefits that they were receiving. In the midst of this fraud and financial waste in 2 states, 600,000 individuals nationwide remain trapped on Medicaid waiting lists due to a lack of state funding. The list could go on, because fraudsters are always looking for new ways to take advantage of the system. Many states have made it all too easy, and unfortunately, it's the most vulnerable that suffer. According to the U.S. Department of Health and Human Services, nearly 10% of all Medicaid spending is improper, and most improper payments since 2010 have been due to eligibility errors. By ensuring that the state is reviewing deceased persons, correctional and employment status, earned and unearned income, and lottery records, Virginia is taking an important step to cut down on opportunities for fraud and abuse and protecting its limited resources for the truly needy. If it is for these reasons that I encourage you to support this bill, don't let the Jacob Chalkies and the Chloe Jones of Virginia suffer because of fraud draining limited state resources. Thank you again for the opportunity to speak today, and I'm happy to answer any questions.
Thank you. Any questions? No, sir. Thank you very much. Charlie Rock, you have other people wanting to wish to speak.
I think that.
Is there anyone else who would like to speak to the bill?
Mr. Chairman, members of the committee, James how to properly dispose of prescription drugs. And we do this simply because these drugs are going into our water. It addresses a really major problem that we have with lack of information about proper disposal of prescription drugs. There is no, that they told me, cost to the Commonwealth. But we have, in recent years, been discovering drugs in the water. They've studied fish, they've studied the water, and they found dozens and dozens of things that are showing up, especially in the Potomac. They're seeing anti-seizure drugs, anti-inflammatory drugs, antibiotics, and even some disinfectants. This is a simple ad at the end of this monograph that gets handed to you every time you get a drug prescription. I'm not asking for anything else. We're just wanting people to get the information on how to properly dispose of a drug at the time that they get it. We have worked with the pharmacies. We have worked with pharma. I've spoken to them about this. Didn't get any objections, really. Apparently there is someone. But I think it's a simple ask. It's an important ask that we let people know how to properly dispose of drugs. I'm not trying to do anything else.
Dr. Murphy, do you feel it hostile if I were to suggest to you that I would work with you for language to be ready by Tuesday that would, in lieu of what you proposed, introduce this and make this a Section 1 bill charging the Board of Pharmacy to come up with a proper framework to address this issue?
I wouldn't view that as hostile.
So, Mr. Chairman, I guess I'm suggesting if it's amenable to the patron, we have the measure go by as we did with a similar matter where we make it some amendment language, and I'll get it to the subcommittee members before Tuesday, and then I can just take it to full committee if the subcommittee concurs. Well, kind of like we did before when you didn't have the language in front of you. That's what I'm saying, like we did before where I didn't have the exact language. We'll just have it go by here, but I can bring it to full.
So we'll send it to full committee with that, a recommendation from this committee, with an understanding that we will have something for the full.
Yeah, I mean, I just want to be clear. There isn't language attached here that tells you what to do. This is a mandate that you need to just include what to do.
I guess my concern is we try to do it this way. It's written the absolute best way, or the better way is to leave that to the Board of Pharmacy.
Right.
Getting input from the stakeholders, the pharmacy community. But I agree with your intent.
Mr. Chairman, I do want to say this is written as part of the code that tells the pharmacist what to do. It says a pharmacist shall in each one of these. So I do think it's worth sending it to the board so they can come back and get, hopefully you can get, if you have a stakeholder like you say, you can get where you want to go.
Right.
For the section 1.
That's fine, thank you.
Mr. Chairman, Delegate Murphy.
Yes.
Otherwise, this doesn't accomplish what you want to accomplish from what your conversation you and I had. As this is worded right now, that says, if the offer to council is accepted. So every time I drive up to the window, I think what the bill says. If I drive up to the pharmacy window and they say, do you understand your medicines? Do you have any questions? And I say no, I won't get any instructions. It won't be printed on that piece of paper. It won't be anything different than it is today. So it strikes me from the conversation you and I had, if we're going to move forward with this concept somehow of letting the Board of Pharmacy, letting the pharmacist determine how onerous this is, how difficult it's going to be, how expensive it's going to be, the entity differences, Walgreens versus CVS versus privates versus Walmart, all have different disposal programs. Are you going to somehow have to have 10 different pieces of paper? Are people that go to Walgreens might want to dispose their drugs at CVS, et cetera? There are a whole lot of issues that are going to have to be worked out.
Well, yes, and I appreciate that. I was thinking more along the lines of even, just the generic, this is where you can go, this is the number you can call, this is the website you can go on to.
But this won't accomplish it.
Okay, and I appreciate that.
Yes, ma'am.
Thank you.
Yeah, you're most welcome. Thank you, Mr. Chairman.
Mr. Chairman?
Delegate
I have a motion. Patron's request for Delegate Lingenfelter's 1999. I think he would like that reported and referred to appropriations to the subcommittee that may not meet again.
assure the committee, subcommittee, that he is working very, very hard to secure those funds with appropriations. So he would like the bill to be given a chance.
That's the recommendation.
What's your motion to?
Motion to recommend reporting to the full committee and referral to appropriations committee.
Do you have a second?
Second.
Moved and seconded. All those in favor, please say aye.
Aye.
Opposed?
And Mr. Chairman, I think that only leaves my measure on the docket, and I'll speak very briefly before I make a motion. Mr. Chairman, in learning a little bit more about this philosophically, I wish the state could put a little bit more requirements into the program. The long and the short, this is all federal money. Secondly, it's federally driven in the rules and requirements surrounding the matter. Again, I wish we could put a little more in it. With that being said, I would ask that the committee just quietly lay this on the table.
Second.
All right. That motion
Why not?
is
Don't say that.
not in favor. So all those in favor, tabling Rocks bill, please say aye.
Aye.
Hearing no opposition, the bill is laid on the table. Completes our business here. Thank you very much.
I want to thank the committee chairman and Ms. Dan.
All right. Thanks to the staff.
Sarah, Jackie. Thank you.
Hey, Miles, he said he was gonna keep you here through that whole conversation so you become better educated. Before he was just gonna.
Is that the only reason we're still here, Mom?
Force.
Yes, we love to know.
He could probably teach.